Welcome, everybody. I'm Kim Hodgson, the immediate past president from the SVS. And I'm here today quite honored to introduce our Homans lecture for 2020. We're also familiar with Homans' sign to diagnose a DVT of the lower extremities. That Dr. John Homans almost seems like an old friend. He was a founder of the SVS and a professor of surgery at the Brigham and Yale. He's also responsible for promoting the ligation of the saphenofemoral junction to treat varicose veins, for advocating venous ligation to prevent pulmonary emboli, and for describing the first DVT associated with a long plane ride. Beyond the world of vascular surgery, Dr. Homans also worked with Cushing and Gross on the pituitary gland. His contributions were so significant to the early days of this organization that a lecture was established in his honor during our 4th vascular annual meeting. This lecture has only been delivered 13 times in the SVS history by some of our most distinguished vascular surgeons. Our Homans lecturer today is Dr. James Stanley. Now, before I introduce him, just on a personal note, I would let you know that I first met Dr. Stanley in 1985 when I was a general surgery resident in Albany and was interviewing for a fellowship position in Dr. Stanley's distinguished and highly sought-after program. In those days, there was no match, so you had to make your best impression at the interview and then wait for a phone call offering you a position. Well, in my case, that phone call never came. Obviously, no hard feelings, Jim, because we're both here today, and I think both of us have done quite well in our careers and pursuits. Dr. Stanley's contributions to our field are extensive. He served as the head of the vascular surgery at the University of Michigan from 1976 to 2004. And during that time, 1 in 8 of the program directors in the United States in vascular surgery were trained at the University of Michigan. His focus has always been on complex cerebrovascular and aortic disease, renovascular hypertension, splanchnic aneurysms, and pediatric arterial cases, where he has a unique experience. He became an honorary fellow in the Royal College of Surgeons, an honorary member of the National Academy of Medicine of Columbia, and an honorary member of the Royal Australasian College of Surgeons. He's authored more than 300 scientific articles in 150 textbook chapters. He had an immense impact on all of us as editor of the Journal of Vascular Surgery from 1991 to 1996. Ladies and gentlemen, please welcome our 14th Homans lecturer, Dr. James Stanley.
Well, Kim, thank you very much. I don't remember the interview, and I'm not sure I want to have you tell me much about it. So listen, it's a very distinct pleasure to give the 2021 John Homans lecture, since the first one that you just heard about was in 1951. Today, my words really represent a very personal perspective that evolved from my caring for hundreds of patients with renovascular hypertension and operating on more than 1,100 adults and more than 200 children having renal artery occlusive disease. 2 seminal events preceded this. First, the kidney's role in affecting the blood pressure was initially recognized in 1898, when Tigerstedt and Bergman at the Karolinska Institute identified a pressure substance that they extracted from renal tissue. They named it renin. Second, the importance of reductions in renal blood flow causing hypertension was confirmed by Harry Goldblatt in a series of very elegant canine experimental studies. Then, in 1938, the year I was born, 2 urologists at Hopkins, Ledbetter and Birkeland, removed a kidney with its obstructed renal artery and cured very difficult to control hypertension in a 6-year-old boy. 2 years later, in 1940, Page and in the United States, and Brown and Menendez in Argentina independently identified the pressure substance in blood responsible for this form of secondary hypertension. They named it differently: angiotonin in the United States and hypertensinin in Argentina. In 1957, the University of Michigan held a symposium on the basic mechanisms of arterial hypertension, honoring Goldblatt's achievements. The host of the symposium were Sibley Hubler, an internist, and David Bohr, a physiologist. Dr. Hubler would become a clinical mentor of mine 7 years later when I was a senior student. Dr. Bohr helped me write my first NIH grant 15 years later when I was in my senior year of surgical training. During the symposium at Michigan, Page and Brown and Menendez put aside their differences in naming the substance and discovered something new they could actually agree, and they jointly proposed the term angiotensin. That name stuck. When I finished my surgical residency in 1972, the culture of the 1970s at Michigan was steeped with hypertensive icons, perhaps the most notable being Jerome Kahn, who headed up the endocrinology division and discovered primary aldosteronism, a syndrome carrying his name, as well as three of my colleagues in Hubler's hypertension division, the second such division in the nation. The first was at the Cleveland Clinic. Just as important was Michigan's inclusion in the national study of renovascular hypertension, which resulted in a series of publications in JAMA, heralded the beginning of a search for this so-called thought to be a curable disease. The radiologic aspect of this study was headed up by Joseph Bookstein, a young angiographer who became a very close professional colleague of mine. For the 2 years during my residency, I was an NIH academic trainee in the surgical research laboratories at Michigan, and one of my projects involved creating a better form of Goldblatt's hypertension using an amyloid constrictor to occlude the renal arteries. This caught Joe Bookstein's attention, and these studies were expanded to our joint investigations of collateral blood flow vessels in humans having renal artery disease and renovascular hypertension, not in the laboratory, but in real people. The supportive culture in the 1970s also involved surgeons, including my departmental chair, Gardner Child, who offered me my first job. Although he was best known for the surgical management of portal hypertension and disease of the pancreas, most didn't know, and I didn't know until he retired and I had a chance to look at his CV, that his first 3 publications as a young surgeon were on renovascular hypertension. I actually think he saw a bit of himself in me during his early days, my early days when he recruited me. And of course, my surgical mentors, William Fry and Cal Ertz, both past presidents of this organization, taught me how to operate. And within a decade, the 3 of us began to work on editing what would be the first monograph on renovascular hypertension in the English language, published in 1984 with 38 well-known scientists and clinicians contributing to its nearly 400 pages. So that was the beginning. The culture in the last half-century found continued clinical investigations at Michigan into the causes of secondary hypertension. Important in this work was the recognition of the 3 distinct diseases responsible for renovascular hypertension. The first, arteriosclerosis, occurred in 2 forms: aortic spillover lesions in 95%, and focal renal artery atherosclerotic lesions in the remaining 5%. The former usually represented a more advanced form of generalized arteriosclerosis. And in 1973, my first year on the faculty, we documented better surgical outcomes when treating the focal renal artery lesions without evidence of clinically irrelevant arteriosclerosis in other vascular territories, something of seemingly logical, but actually wasn't much appreciated in those days. Then 2 years later, in 1975, we categorized the 3 basic forms of the second major renal artery disease, arterial dysplasia, a classification that extended the original work of 2 pathologists, one at the Cleveland Clinic and one at the Mayo Clinic in their earlier work. It stood the test of time. The first type, animal fibroplasia, occurs in two forms. Primary disease, like the central stenosis, with normal vessel wall architectures other than the very cellular hillocks of animal tissue encroaching into the lumen. Its cause is unknown, but it's considered very progressive in most cases. The other type is secondary animal fibroplasia, seen most often with associated developmental renal artery or aortic narrowings, in which case all three vessel wall layers are abnormal. There was no sex predilection in either of these cases. Second is medial fibrodysplasia, the most common form of arterial dysplasia, with serial stenoses alternating with intervening mural dilations, accounting for its string of beads appearance and its corrugated luminal appearance. The medial smooth muscle cells are very abnormal in this disease. They appear blue rather than the normal red with the Masson trichrome staining. Medial fibrodysplasia invariably affects the female sex. Third is perimedial dysplasia, characterized by serial stenoses, but no mural aneurysms, and colors would appear to be excesses in elastic tissue. Like the former type, the female sex is most often affected. Other than the renal artery, the most commonly affected vessel is the extracranial internal carotid artery, which is known to be subjected to axial stretching with external rotation and hyperextension of the head, perhaps contributing to its dysplastic development, something we postulated was an etiologic factor for arterial dysplasia occurring during the stretching of the renal artery and tonic kidneys, known to be much more common in female sex and may contribute to the medial fibrodysplastic disease. In such a setting, it's hypothesized that the smooth muscle cell has two options, one leading to cell death, forming the mural aneurysms, and the other being transformation to a secretory myofibroblast and formation of the stenosis. These two events were confirmed by transmission electron microscopy of these two dysplastic processes, published by us in 1978. It was the first report on the ultrastructure of arterial dysplasia, and only one similar article has appeared in the subsequent 50 years. The third major type of renal artery stenoses are considered developmental in nature. They're diminutive in size and markedly deranged arteries, likely evolving from an embryonic misadventure around the 25th day of life, occurring as the two dorsal aortas fuse and the metanephric vessels from the kidneys attached to the newly formed single channel. The result is a failure to have normal aortic connection, eventuating in what has always been seen as a circumferential osteostenosis, as in this case. Interestingly, abdominal aortic coarctations coexisted in more than a third of our cases exhibiting developmental renal artery stenoses, the most common involvement being suprarenal followed by intrarenal coarctations. In rare circumstances, abdominal aortic hypoplasia with diffuse aortic narrowing accompanied the developmental renal artery stenoses. The etiology of all these aortic narrowings appears related to events surrounding, again, the fusion of the two embryonic dorsal aortas around the 25th day of life. You know, anatomy is static. What we've seen in the past is what we see now, but our understanding of the renin-angiotensin system has undergone a number of important changes in the last half-century. The renin gene and angiotensin gene, the key elements in initiation of the renin-angiotensin system, are both on chromosome 1. These genes exist in lesser vertebrate life, like fish, without complicated water-salt balance issues experienced by humans, perhaps serving an equally important function in lesser animals related to inflammation and healing, not fluid balance and not blood pressure maintenance. The principal function for renin, a proteolytic enzyme produced in the JG apparatus of the kidney, is to act on angiotensinogen, an alpha-2 globulin formed in the liver to form angiotensin 1, which when acted upon by converting enzyme forms angiotensin 2, and that's where the action is. As a subnote, converting enzyme 2 inactivates angiotensin 2 to produce angiotensin 3, and that's the target for COVID-19 virus attachment being most prominent in our lungs. Angiotensin II binds to angiotensin I receptors, and that results in vasoconstriction and, as I'll mention later, tissue remodeling. Angiotensin II also binds to angiotensin II receptors that counter the many effects of angiotensin I receptor activation. Another side note, estrogens reduce the density of angiotensin I receptors and increase the density of angio II receptors, perhaps contributing to the delayed cardiovascular disease seen in the female sex. Important in renovascular hypertension are the two well-recognized downstream effects of angiotensin II, arterial vasoconstriction and increased adrenal gland aldosterone production with its sodium retention and hypervolemia. Too much fluid and not enough space, leading to refractory hypertension. Two of my own personal heroes are John Lara and his wife, Jean Seeley, who defined the kidney's addition of 48% more renin to the blood pressure as it passes through the kidney, irregardless of whether you're on a vegetarian diet with nothing but lettuce and water or you're eating potato chips and beer with a lot of sodium. That's a constant thing. They demonstrated this by assaying renin activity in the renal venous and infrarenal cave blood. It's known that in some cases, renin production from one kidney could increase with no arterial blood pressure response as long as it didn't exceed 48% and the opposite kidney's renin was suppressed. But renin production over 48% exceeds its possible inactivation by the liver, and hyperenemia and systemic arterial hypertension occurs. We hypothesize that this is what occurs in renovascular hypertension, and with a great deal of coaching from Jean Seeley, we ended up studying 85 renovascular hypertensive patients who had successfully undergone a unilateral renal artery stenosis correction and noted prognostic value of assessing the renin production from each kidney in the form of indices. Those with contralateral suppression were cured. Without that suppression, they may have been improved with restoration of normal blood flow to the hypersecreting kidney, but they weren't cured. And remember, if just say both kidneys made 35% of renin coming through them, that would be a total of 70%, which way exceeds the maximum of tolerable of 48%. Simple renal vein renin comparisons of one kidney to the other in the form of ratios are non-discriminatory. Indices are much better indicators. But there's much more than fluid balance at stake, with inflammation being linked to angiotensin II, and that has significant clinical import. In 1972, in the New England Journal, and 3 subsequent papers over the next 2 decades from Lara's group, it was noted that patients with increased renin-angiotensin activity had an increased risk of heart attacks and stroke compared to those with normal renin levels, despite both groups having equal blood pressures. 3 months later, the same journal, Higashi related oxidative stress to renovascular hypertension in an activated renin angiotensin system, and this was clearly much more than a fluid problem. So what's happening? Well, angiotensin II directly and indirectly affects the arterial vasculature due to increased oxidative stress, which through a number of actions on vessel wall elements leads to arterial remodeling. Angiotensin also increases LDL oxidation and decreases endothelial-derived nitric oxide, both factors known to facilitate atherogenesis. It's much more than a theory. Many of publications allude to the fact that an activated renin-angiotensin system in untreated or inadequately treated renovascular hypertension accelerates atherosclerotic plaque formation, instability, thrombosis, and aneurysm formation. Such is not an issue to be ignored. And that makes therapy very important, and the culture of the last half century has witnessed considerable changes in the treatment of renovascular hypertension. The pharmacologic therapy more than a half century ago did not include these 3 categories of drugs that interfere at predictable places in the renin-angiotensin pathway from the beginning to the end. And in many circles, they're the mainstay of renovascular hypertension therapy today. Let me comment on attempts to restore normal renal blood flow. which in reality is the root cause of renovascular hypertension. Many decades ago, I produced 3 therapy algorithms for a surgical text for each of the 3 renal artery disease types. The one about arteriosclerosis was modified a bit and used in preparing the American College of Cardiology American Heart Guidelines, which the SVS supported. And when I submitted it to the writing committee, one of the interventional cardiologists scribbled on the algorithm that this was all, quote, bovine nitrogenous waste, unquote. But those were not the exact words that I read when it was returned to me. The algorithms were based on what worked and what didn't work, with nearly 1,300 renal artery reconstructions of my own in rather thoroughly and perhaps overly investigated patients. His own published experiences were solely based on biplane arteriograms. So much for his opinion. At time, the most commonly undertaken revascularization procedures were open aorta renal bypass. The first aorta renal bypass was a femoral artery homograph placed by Humphreys and Patas at the Cleveland Clinic. The first autogenous saphenous vein aorta renal bypass was by Berrien Bill DeWeese, Jim DeWeese's brother, who was my mentor as a senior medical student at the University of Michigan. A few lessons were learned early. Inclusion of a vein branch to create a more generous aortic anastomosis, and spatulation of distal anastomoses to prevent late strictures. And of course, hepatorenal and splenorenal bypasses could be undertaken when the aorta was unfavorable for a proximal anastomosis. The first renal artery endarterectomy was performed in 1952 by Norman Freeman in California. He was an exceptional intellect and surgeon, but mental illness, treatable today, found him working in the San Francisco VA hospital's medical record room in his later years. His loss was huge to our specialty and gives importance, I think, to today's awareness of maintaining one's mental wellness. A renal endarterectomy, for most part, is really an aortorenal endarterectomy, removing the aortic plaque with this arteriosclerotic tongue spilling over into the renal arteries. Today, the reality is that few open renal artery reconstructions need be undertaken given the availability of endovascular interventions. This technology was introduced by Andreas Grunzing, a close friend of mine, seen in this 1982 snapshot with his wife Margaret and me during a week-long trip to Japan. 3 years later, 1985, they both would lose their lives when he lost control of the airplane he was piloting. Grunzig's death was a tragic loss to the endovascular community, especially to interventional cardiologists dealing with the coronary arteries. But for us, his legacy remained in his 1978 publication in The Lancet, less than a decade earlier. It changed everything. The technical success of endovascular balloon angioplasty with stenting of renal artery stenosis due to arteriosclerosis is well established, and angioplastic dilations of stenoses due to arterial fibrodysplasia are even better. But since its introduction, percutaneous renal angioplasty has been controversial. We were part of the entrance of this technology, but from the very beginning, irregularities in its application to clinical practice were commonplace, and as a result, the reported outcomes were mixed. There were clear anatomic and physiologic criteria that supported the successful use of endovascular interventions, yet it seemed that many good physicians and surgeons ignored these guidelines. I was a consultant to CMS regarding reimbursement for renal PTAs, and it was a very uncomfortable experience for me, to say the least. Unfortunately, some interventionists believed the anatomic criteria were ill-defined, and physiologic criteria in their practices was rarely considered. I believe it's illogical that a successful renal PTA with stenting and arteriosclerotic stenosis should have a less salutary benefit than afforded carefully selected patients undergoing open surgical therapy. Unfortunately, the 3 studies that might have confirmed that tenet, which I hoped would, have all had major flaws, in my opinion. Had I used these trials criteria for treatment in my own open practice, my outcomes would have been much less beneficial and in some instances meaningless. My thoughts were not in isolation. After reviewing the choral results, the authors of one publication stated it all, quote, every major trial completed for this topic thus far has suffered from major methodological flaws that limit the validity and external generalizability of their results. And finally, quote, trials regarding endovascular renovascular revascularization have resulted in a stagnating equipoise, unquote. I really couldn't have said it better or clearer in my own terms. The interventional therapy of pediatric renovascular hypertension is better defined and certainly less controversial. For nearly a half century at the University of Michigan, we've documented a learning curve at treating this disease in children, and we've learned a lot. First, during my initial year on the faculty, I reported on the fate of 100 aortorenal vein grafts, the conduit of choice in those days in pediatric reconstructions, and documented aneurysmal vein grafts in all the children, likely due to an inadequate vasovas form occurring in childhood. This resulted in a major change in our practice. So thereafter, when a bypass was required, we used a segment of the internal iliac artery, something that had always been touted by Jack Wiley in San Francisco. However, given that most stenoses were osteolocation, we soon reported that aortic reimplantation of the normal renal artery beyond its stenosis was to be favored, and the reimplantation has become today's standard. And as with many vascular procedures, there are many alternative sites for reimplantation of the renal artery, albeit requiring some degree of technical expertise and practice. The outcomes following renal endovascular therapy in children with or without cutting balloons or stenting are poor, and remedial operation successes are limited, with failure following endovascular therapies resulting in nearly a 20% nephrectomy rate and a cure of hypertension in only 25%, much poorer results than accompany primary open operations. The increasing coexistence of abdominal aortic coarctations in pediatric renovascular cases treated at the University of Michigan has also seen a change in our surgical practice. Whereas thoracoabdominal bypasses were preferred in our early experience, there are reasons why today they are usually undertaken only when the aortic narrowings cannot be easily treated with patch aortoplasty. Nevertheless, a bypass may be essential in creating new abdominal aortas when the native aorta is exceedingly narrow or nothing more than an atretic cord, such as in this case. Today, with less severe aortic narrowings, we favor patch aortoplasties. We attempt to oversize the reconstructed area so as the child grows into late adolescence and adulthood, the reconstructing aorta would not represent a hemodynamic narrowing, causing a pressure gradient. Such patch aortoplasties have stood the test of time, as evident in this young child with an intrarenal coarctation and bilateral renal artery osteal disease who had a normal pairing renal arteries at their orifices, and aortic contour was normal at 28 years of follow-up. As mentioned, renal artery reconstructions in the Michigan experience over the years have been accompanied by an increasing percentage of children undergoing coexistent aortic reconstructions. Accompanying this has been an increasing number of children requiring medications to normalize their blood pressure. That's generated obvious concern on our part. The fact is that postoperative blood flow may not return to normal after thoracoabdominal bypass. That possibility led to a number of studies at Michigan's Computational Vascular Biomechanics Laboratory, headed by Alberto Figueroa, who holds a joint appointment in both vascular surgery and bioengineering. Indeed, we discovered what we were concerned about. The analysis documented continued turbulent renal blood flow, importantly. This modeling allowed us to test different sized bypasses and patches, and no surprise, the aortoplasty was the best fit. My own personal experience with open surgical therapies for renovascular hypertension in a total of more than 1,300 patients has provided me with a certain perspective as to what I think works and what doesn't. Remember the early days, we had different expectation when treating those with focal renal artery atherosclerosis compared to those with generalized arteriosclerosis. The latter manifests by clinically evident carotid, coronary, aortic, or even lower extremity disease. It makes a difference. And the generalized arteriosclerotic group unlike the other categories who experienced greater than 90% benefits, they didn't do so well. 27% didn't benefit at all, and the operations carried a 2.8% mortality, mostly in patients who had preoperative renal insufficiency. In contrast, those individuals with arterial dysplasia or developmental renal artery disease did exceedingly well. I performed my first renal revascularization in 1972 during the last month of my chief residency, and my last case as a senior surgeon was a little over 4 years ago. Among the 7,100 operations that I performed as a vascular surgeon, the renal artery obviously has had a special place in my heart and in my career. But numbers aren't everything. My real joy as a vascular surgeon came from the gratitude of patients and their families who entrusted their care to me. And along the way, I learned a lot from those vascular surgeons who were on the University of Michigan faculty. They made every day of my work rewarding. For more than a half century, I've been privileged to work as a surgeon in the shadows of the University of Michigan in Ann Arbor, at the University Hospital and its Cardiovascular Center. Along the way, I've been accompanied by my college sweetheart, and wife of 60 years, Nancy, who's here in the first row with me today. She's heard these words that I've just uttered more than 100 times, manyfold, and she's been the sort of the glue of keeping me together with my academic career. I want to thank you for granting me the honor to present the Homans Lecture. Peace.
Thank you, Jim, for an outstanding review of the history, pathophysiology, and treatment of this uncommon disease for us now at this point in time. That was an excellent lecture. Thank you so much. We're going to go ahead and dismiss the group at the moment. We'll reconvene at 10:30 for the next plenary session. Thank you all.